Again, Ijaz Hidayat is with you with new talk and with new discussion. And today, uh, I have special topics for you. And MacBook. This MacBook is gifted by my lovely wife, and thank you so much, Nishaba, for such a beautiful gift which you have given to me. And really thankful to Nishaba Ijaz, my lovely pretty wife, for giving me such a beautiful gift. So before I'll start my presentation, I'll just need to on my laptop. So my password. Let's talk about the oxygenator failures. So what is oxygenator failure? We'll start. So what do you think about the oxygenator failures? What come in your mind about the oxygenator failure? So the definition of the oxygenator failure is decrease in oxygenation or retention of the CO2. In a simple words, the oxygenation is not taking place and the CO2 is increasing in the blood and oxygen is decreasing in the blood. As we know, the function of the membrane oxygenator is to remove CO2 and increase oxygen in the blood, so we can supply the oxygenated blood into the different part of the body to keep the tissues alive. So what can be the diagnosis of oxygenator failures? Number one, it can be machine factor, and number two, it can be related to the patient's factors. So oxygenators failure can be number one machine related, and number two is patient related factors. So we'll talk about the machine related factors. So if you see the ECMO machine, so you will find the TMP, the base of the TMP, the time when you started the ECMO, extracorporeal membrane oxygenation, or you start mostly will find especially in the membrane oxygenator and especially for the ECMO. So your TMP become a doubles. Like if you have the 40 and it will going to be 50, then you have to think about. Or if it more than 50 millimeter per mercury, difference between the pre-membrane and post-membrane, or we can say delta P, or we can say transmembrane pressures. So then you have to think about the failure of your oxygenator, and you can do the changing of your membrane in electively, not in emergency situations. Number two, ineffective sweep gas. So although you increase the sweep gas, but still the PCO2 is still on a higher side, and you're not able to remove the CO2 from the blood, and PCO2 partial carbon dioxide pressure is more than like a 60. Then third is the post-membrane PO2. So usually what we used to do, we do the post-membrane oxygenation, post-oxy blood gases, and in the post-oxy blood gas, we see the trend of the post-oxy, and if we find, just wait a minute, is already on. So the post-oxy should be above than 300 millimeter per mercury, and in especially in the VV ECMO, and in a VA ECMO, before doing the post-membrane oxygenation, always keep the FDO2 or FiO2, make it on 100%, and then you can do the blood gas. And if the PO2 is below than 300 millimeter mercury, it indicate that your oxygenator going to be failed soon. So you can do MDT meeting and decide to what were the future plan for either you are going to change the oxygenator or you keep your eyes on your oxygenator's function. And if your PO2 is trending is going down, post-oxy trending is going down, then you can do the gas transfer, and gas transfer factors will tell you that when to change your oxygenator. Now we'll talk about the patient related factors. So first we talk about the machine related factors. Now we're going to talk about the patient related factor. So patient's cardiac output, mean heart rate, it will be increased. Increase in consumption of the oxygen, patient might be in sepsis. Blood oxygen content, so you have to see the patient hemoglobin hematocrit. So if needed, you can add a blood. Then progressive consumption of the coagulation of factors, so fibrinogen and platelets. So you have to focus, see, think the patient's APTT level or INR level or APTT, INR, ASCT, the test you have to see and see if it is in higher sided, and you can just do like start some anticoagulations. Then hemolysis, fungal infections. So these are the factors patient related. Number one, cardiac output. Number two is your increase of oxygen consumption. Number three is blood O2 content decreased, and then progressive consumption of the coagulation factors. And number fifth is your hemolysis fungal infection. What can be the effects? It is not done electively. For VV ECMO, you will find a profound hypoxemia, then hemodynamical collapse, and then cardiac arrest. If you talk about the VE ECMO, the effect will be you need a full support, cardiac arrest, some native cardiac output will be there, patient will going to be in a hypotension, then hypoxia. So these are the effects you will see, and what can be your response on that time. So you have to discuss with the ECMO consultant and perfusionist. If they are agreed, proceed with the change of the circuit. What can be the prevention for to avoid oxygenator failures in emergency situation? Oxygenator, daily clot inspections, direction inspection, daily pre and post membrane blood gas O2 transfer, daily check of the transmembrane pressure, trend of the baseline of your TMP plus revolution per minute RPM versus the TMP. Size the membrane hourly to avoid the condensation. Coagulation properly, anticoagulation, pre-membrane heparin preferred. Daily check for the coagulation factors. So conclusion is oxygenator failure causes are related to machine factors. Machine related factors should be addressed first, then oxygenator failure features, worsening of the gas exchange, TMP is above than higher or double than the baseline, PO2 decreased, O transfer decreased, and then you can change your membrane. So I'll try to highlight some few points of oxygenator failure factors which is related to machine, and few factors related to the patients. Hope today's sessions gave you some brief idea about how to prevent oxygenator failure and do changing of your oxygenator on a elective mode instead of the emergency mode. So if you like this video, please share with your group, with your community. Share, like, comments, subscribe is important. And the last, have a nice and very, very good day. Take care. Bye bye.